Kalavayla çalışırken, evet, ben de çekeyim mi sizi? Ben de bir çek.
Through all the stages of the nose that you can make today, because it will end up in shreds. So let's go back to day one. You remember the first incision, the hemitransfixion incision, the tunnel on the right side, on the left side for right-handed people, the inferior tunnel. The first osteotomy you ought to do will be the, well, I'll let Dr. Palmer handle it. Plan it in the best way you think so that they'll have maximum use of the...
I think sometimes double osteotomies, and when performed first, the upper level osteotomy or the low osteotomy. That's very important to start beginning the upper level osteotomy. Otherwise, the bone is mobile, of course. Then you have many types, 3 types of lateral osteotomy. A low-to-low osteotomy, which parallels the nasal-optic groove, and then you have to do a transverse osteotomy, then a medial osteotomy to mobilize the nasal pyramid. Well, the sequence, my sequence is lateral, medial, and transverse. In some noses, you can't do the transverse osteotomies. You can do maneuvers of laxation of the bone. I didn't advocate these maneuver in each case because he can give a rocker formation. I think that Dr. Simons will agree with this statement. When, as far as I am concerned, when I have a white radix, sometimes it's necessary these are the nasal bones. And this is the process of the maxilla. When you do an osteotomy like this is the inner canthus. You can have this kind. I start always like this, and then I move the chisel here. Or the osteotomies we showed Dr. Simons is a carved osteotomy. When you have a wide dorsum, when you have mobilized the bony pyramid with a lateral and medial or paramedial osteotomy, and then you do a transverse osteotomy, sometimes you can't narrow the pyramid because here there is bone. Then I, with a Ruskin ronger, I take away a wedge here and here, so I can close the other groove. So I will start with a lateral osteotomy. I would check the level. I would see the anatomy, because of course this osteotomy is not done into the nasal bones. It is done into the maxilla bone, into the frontal process of maxilla.
Okay.
And you said you wanted to cut the skin. The first thing I would do when you cut the skin is to look at what we talked today about the difference in the level of thickness. That's critical in I think, in hump removal, to understand it. And you'll have the best opportunity today. When you make an incision down the middle of the nose, check and see if what we said today is not true in every nose. That it's much thinner right over the key area, or the keystone area, than it is anywhere else. It'll be thicker up at the glabella, it'll be thinner. That's the first thing. Second thing, before you leave this room, take a look at the cadaver skull up here, because it will tell you, without dissecting away from the nose, you'll be able to see exactly in a nose how little the bone really contributes. And when you engage an osteotome, at least it's important when you, to make a cut through bone with a chisel. Chisel's the right term here. When you engage it, what you're doing is engaging it at the piriform aperture. It's very important, and it's most easily seen on a skull like this, that you're going to go down and engage it at a right angle, I believe, at right angle to the bone. Now the bone comes inward and upward. When a patient is lying on the table, the piriform aperture comes in and up this way and like this. So that when I put the osteotome in to get it at right angles, I don't come like this, but I will come down and outward. It's the same analogy as somebody cutting a diamond. If you get it the right angle, you cut through and you can do a cut. And if you're off, it shatters and doesn't go in the direction that you want. When you use an osteotome, it will go exactly as you want it if you engage it, begin the engagement at right angles to it. So it's very important you understand to be at a right angle. Also, when you look at this skull, you'll see that you're always above the inferior turbinate. So that the concept of doing a lateral osteotomy and somehow then obliterating the airway because you move the inferior turbinate is wrong. You're above the inferior turbinate. You have to be. Because you would have to do that down into the maxillary bone itself. The next thing, as Dr. Lapidat said, is to appreciate on this bone that you really are in the frontal process. The nasal bone itself is relatively small, and everybody will have a suture line that you'll see. You're down in the frontal process, and the way in which it curves around, it'll curve right at the inner canthus, and that's why I think you can come up easily without changing to transverse osteotomies and things like that. If you're going to do both the osteotomy and the intermediate osteotomy, it's always best to do the intermediate first, the higher one first. And I think that's important. As I understand the push down, I don't do the push down, but as I heard it, you want to do the higher osteotomy first, and then the lower one. So if you're going to go through this, would you rather they did the intermediate first?
I would think so.
Or at least on one side. You may want to try one side and do the low one and see if it'll fracture. You understand the difference between intermediate and the lower? The lower one is going to go down along the nasofacial groove. Bone. Let's see. How are we doing this? If the nasal bone is here and you're coming through the process, and this is the piriform aperture here. First of all, you're going to engage that osteotome downward and outward. Let's say we're working on the left side here. The intermediate one is you're going to engage it at the same area, but you're going to take the incision and you're going to take it up towards the radix, which is up here. And then you're going to come back and do the lower one down along the base. In the push down, I take it you want to take out a certain amount of bone here or not?
Not necessarily always. I'll refer to it in a minute.
Okay. The reason for double osteotomies there are a couple reasons I use them. Number one, if you've got a very convex bone and you want to break the convexity, you know that it's wide and you can't take it down low enough to really narrow, but it's just a wide bone. You're trying to do a controlled fracture of that bone. And so that you're really shattering it through two osteotomies and taking the convex surface, taking a line through a higher one, and then another one to break it in. And you may add, as Dr. Palmer said, a third osteotomy here, and that would be a medial one that goes through the top. One of the things you'll want to do after somewhere along this line.
Top is a transverse.
No, the transverse would be this way.
Oh, I see, you've got it right.
You're looking at the lateral wall here. I'm sorry.
Oh, I see.
You're looking at a lateral.
I'm sorry.
Okay. The medial, so that number one, very convex bone, I would do a double. Doing the higher one first and then this one. The second situation for doing this is as we had in the OR the other night.
Absolutely.
If you inadvertently do your osteotomy and you feel bone lower, it's what we call a step-off deformity. In other words, as you palpate, you suddenly see that the bone superiorly is in, but you've got still that frontal process that's out. And it's going to show. And it's like a step-off deformity. To get rid of it, very easy. Just go back lower, do the lower osteotomy, and just impact it. No problem with that. So that would be the second way I would do that. And then, as I say, if you've done the osteotomy and it's not moving in, suppose you've got a wide nose and you can't take a hump off to create an open osteotomy, then you've got to get the complete fracture, you'll do a medial osteotomy, along here. But you won't do it in a straight line like this. The osteotomy will go, and one of the things you ought to see with the osteotome is how it travels towards the inner canthus. If you're a golfer, it's going to fade or it's going to hook towards the internal canthal region. And the reason it will do that, and you ought to see it here, is if you get up high into the nasal bone, it gets very thick in the radix. The thin portion is going to be lateral to the medial line. So that you want to, number one, never carry it high into the radix. There's no reason for ever taking an osteotome and taking a straight line up into the frontal process, into the frontal spine region off of the frontal bone. That makes no sense because it's too thick. You won't break anything. What you will do is to create a line of weakness here that when you try and push in the osteotomy here, it may splay apart. In other words, you can push it in lower because you've got space, but it'll come out a little bit up above, and that's called a rocker. So you don't want to do that. Your osteotomy, if you do a medial osteotomy, you can do this in the lab too, should go towards the inner canthus, just slightly up to this process, and really join with the lateral to complete a complete transfixion, a complete osteotomy of the bones, so that it's okay. So let's not take it now. You got anything else?
Evet, burası İsrail'in